Welcome to the podcast where we discuss health, health span, lifespan, and longevity. I'm Dr. Noor Gajraj. Well, unfortunately, I've had an injury today. It's part of aging, and it's something that we're going to all have to overcome. So this is a really good opportunity to talk about Achilles tendon rupture. So it's Friday night. 3 hours ago, I was doing a little exercise with my wife. This was the exercise I was doing. You can see I'm running in place, but I think the critical event was running in place while leaning forward. That must have put a lot of stress on the Achilles tendon. Just a few things about Achilles tendon rupture. Who gets it? It's the weekend warrior. This injury is most famous for striking active adults who play sports sporadically rather than professionally. It is significantly more common in men than women. The ratio is often cited around 10 to 1. The peak incidence is between 30 and 50 years old. It typically happens in the watershed zone of the tendon, about 2 to 6 centimeters above the heel, where blood supply is naturally porous, making the tissue more prone to degeneration and snapping. Many patients report hearing a loud crack or pop, often comparing it to a gunshot or a branch snapping. The hallmark symptom is the sensation of being kicked or hit hard in the back of the calf, even though no one is there. There is usually sharp, immediate pain in the back of the ankle, though this can sometimes subside into a dull ache surprisingly quickly. And then I suddenly felt like a piece of wood had hit the back of my ankle. And I looked down, I think there was nothing there, it hadn't hit anything. And then I noticed there's this depression. See, this is the Achilles tendon. And then there's a drop off, right? That's the rest of the tendon. And right here, there's a depression. And it feels to me like it's ripped in half. Here's an interesting clinical sign, actually. This is called Thompson's sign. Now, usually when you squeeze the calf, you'll see a little movement of the foot pointing downward, right? Oops, no, that was yeah. Now look at this side and look at the foot. Absolutely nothing. Kind of distressing, actually. Anyway, I did speak to a colleague of mine. Luckily, I know Dr. Joseph McNutt. I've actually just come from the MRI center, and he's going to be reviewing the study, and we've talked about surgical repair next week, Wednesday. So, and my wife's been very nice to me. It's great to have a good partner. And do you have any comments about this evening? Quite stressful, right?
Yes, very.
That's it. Okay, so I am going to sign off, and probably next time you'll see me will be going into the operating room. So here I am in recovery. I have my IV, and Dr. McNutt has marked the surgery site, which is the left Achilles tendon. So off we go. Here are some pictures taken in the operating room. You can see the incision and the repair. Well, I had my Achilles tendon repair just 2 hours ago. I'm at home. I've got this mobility device, which is it's called Knee Rover, and it allows me to get around. So I'm going to work on my recovery. I'm going to tell you what I'm going to do. But the first thing is to make sure that my protein intake is satisfactory. You may know that the recommendation is now 1 gram per pound of ideal body weight. So I'm going to go on a body weight of 160 pounds. That means 160 grams of protein. So, for instance, one of the protein drinks that I use is 42 grams. I'm going to put 10 grams of creatine in there. And depending on what else I'm eating, I may take 4 of those, which will give me the 160 grams of protein. I'm also going to do some things with supplements. I'm going to up my vitamin C, and I'm also going to be doing some exercises to maintain muscle strength, because one thing after surgery is that you can lose muscle mass, and I don't want that. So as I say, it was only two hours ago I had this procedure. An excellent anesthetic. I had a popliteal nerve block. It's a block done at the back of the knee, and it's given me analgesia. I'm not feeling a thing. I haven't had any pain medications. And then, of course, that was done by Dr. Merritt, who's an extremely good anesthesiologist. And then, of course, Dr. McNutt did the surgery. It's important to have a good surgeon, good experienced surgeon. They tend to be able to do the surgery quicker and with less tissue trauma. So all in all, very good anesthetic, very good pain relief, and very good surgeon. So far so good, and I'm going to be telling you how I'm going to deal with the recovery. So this is my wife, Cheryl. She's really been good, taking excellent care of me. How do you think it's gone, Cheryl?
It's been better than expected, honestly. It's just amazing how great you're doing one day after surgery. Dr. McNutt is an excellent surgeon. Dr. Merritt was a great anesthesiologist. He used a nerve block that can last up to 3 days called Exparel, which seems to be doing great. And so happy with the staff at the surgical center. I think it's been awesome.
Yes, it certainly has, and I'm very pleased as well. No pain, no problems at all, so it's great so far. Please subscribe to my channel and read my new book, 100 Pathways to Longevity. Add 25 years to your life, available on Amazon.